Good afternoon. Now that you're ready for your post-lunch nap, I'll try to speak lively. If you have to get up and stretch and do a few jumping jacks, I won't mind. I would like to echo what my colleagues have already said today, that I'm really delighted to be here, to be in your country, to be in Mexico City, and I hope that I will provide you some of the lifestyle information that I know several of you have been asking for, and if I don't, please come and get me afterwards. So what I'm going to be talking about today is lifestyle interventions, which I believe is good medicine for reducing chronic disease risk. So today, here's what I hope to accomplish. I'm going to talk a little bit about theories of behavior change. I'm not going to go into great detail, but I think it's important to bother with talking about theories of behavior change because these principles have long been used to treat obesity and many other conditions, including psychological and psychiatric conditions such as depression. So this is what I see as the roots of behavior change, and I'm going to review some of that. I'm going to talk about some of the core intervention strategies, what I think is essential or critical based on the evidence, what works for coaching self-management, what psychologists like to call self-regulation or self-control of diet quality, activity, and lifestyle behavior. And then I'm going to talk a little bit about the evidence base. I'm only going to go into about the 10 or 15 or so last years, and I'm going to use some illustrations from the United States Diabetes Prevention Program, which is by no means the only evidence-based obesity and diabetes prevention program, but I think provides a nice illustration of what can be done. And I'm going to talk about some other translational studies. How do I make this work in my community, in my location, in my hospital? So, I am telling you for about the 15th time that many of our daily behaviors are inextricably linked to energy balance. And there are some things we can control better than others. So for example, if we work in an office at a computer, that's our job. But do we need to eat? Do we need to take our lunches at the computer? I know I do more days than I really probably should be, or could we be taking a 15-minute walk? Traffic. Some of us commute, there's no way around it, but perhaps there are ways of mixing commuting with other forms of movement and transportation. There's a lot of data to suggest that we eat out a lot and not at home as much. One is not superior to the other, but it affects our energy intake. Of course, we've talked a lot about the tax on snacks and sodas, and that leisure time is increasingly sedentary. Some of these things we can control, and for those of us who are working right now with patients or trying to design programs, these are the things we can be thinking about. So in essence, what I'm saying is that in this 21st century, we need lifestyle skills to deal with an increasingly toxic environment. A generation ago, we got up, we went to work, the meals were the meals that we took, and now it's a different world. So we have to be smarter. I'm fond of saying to clients, can you make these things work for you as opposed to against you? So we have to work smarter in our current toxic environment. Fortunately, and this is where it's kind of fun to be a behavioral health psychologist, the eating and the activity environment shapes our behaviors in certain predictable ways, and we can use some of those same principles to try to shape new behavior. The learning principles have a fundamental pattern, and this is based on research. So even, and this is again, Dr. Mozaffarian, several others were saying, even as we understand the complex physiology of obesity and diabetes, we understand epigenetics, even as these things advance, environment times behavior can lead to illness, or what we want is environment times behavior to lead to health. But how? So Mexico is clearly taking bold steps, more than most, to modify the environment, address the actual food supply, and the built environment. And what lifestyle interventions aim to do is help people become more self-aware, simply develop greater awareness, not be as asleep at the wheel, as it were, in terms of what's going on day to day, and to take charge of what's around them. So a couple of learning theory basics. I'm going to be very brief on that. We still, even as much as our knowledge has changed about learning and behavior and the environment, classical conditioning, which was basically the experiment done by Dr. Pavlov with the dogs and the meat powder, that principle is still in effect many, many times over. There is cue control. So an example of that is you go to a movie theater and you want popcorn. You don't, at least this is in the States. I don't know what movie theater going is like here, but you don't want a little tiny bag of popcorn. You want the big lap-sized bucket of popcorn. Or in the evening when you're watching TV, if you get used to eating snacks, that becomes a habit. It's a behavior. It's repeated over and over and over again. What a behaviorist will tell you is the more a stimulus is paired with a behavior over and over again, the habit will strengthen in reliable ways, but you have to break that chain. Operant conditioning, this is the work of B.F. Skinner. This is work that was done literally mid-last century, but these rules still apply. And in fact, doing something like a drink tax or a soda tax or a snack tax is actually a very radically behavioral move to change the environment, to set up different histories of reward and punishment. So here's an applied example, though. And this is something that we talk with our clients and participants about a lot, is if physical activity gives you discomfort, if you proceed too quickly, if you do too much, you will avoid it. This is a normal learning pattern. We can predict that. If the scale is giving you bad news, you stop weighing, and so on. It's what we would call learned avoidance. We are motivated to be more comfortable, and we do not want to feel psychologically or behaviorally incompetent. And so it's normal to sort of avoid those situations that cause us distress. And then social cognitive theory, several of my colleagues have mentioned that. This is the work of Bandura. It actually began with children, looking at modeling and aggression, and there's a very, very long theory of how we appraise the environment. They use terms, I'm not going to use all of these, it's a little jargony, but terms like personal agency, believing that you can impact your environment, having belief of self-efficacy, that you have capacity for self-control. Many people who come into weight programs will say things to you like, I feel hopeless, I feel helpless, I'm out of control, I must really be lacking in some kind of character trait or willpower. And a lot of what a behavioral psychologist does is try to reshape that as learning and habits and how to learn a new behavior and how to address barriers and how, I believe Olivia said, to build a culture of health competency. And there are so many more theories. I'm not even going to go into all of these theories, but the point that I want to make about the theories is that they're mostly used by researchers to design the models in the research projects. So Dr. Herman talked about this idea of behavioral economics. There's a lot that can be done to predict the mediators and moderators of change, but it's not going to build the lifestyle skill per se. To build the lifestyle skill, to lose a pound, you still need to affect energy balance. So my point in giving you that little psychological behavior therapy 101 is that lifestyle management can be good personal medicine when it's goal-based. It's important to set goals. When there are structured programs that help an individual believe that they can exert some control, have some sense of control where they live, work, and play. It also is effective when it builds new skills, when it is done in a context where you can garner social support and build social norms with your family, your social institutions, and your community. So this is the whole piece of the environment and behavior working together so that it promotes healthy behavior, doesn't hurt it. And many of you have probably read some of the articles and theories of Bandura, but this particular one is really an excellent description of how you go from the personal to the societal, health promotion by social cognitive means, an article from 2004. Okay, so how do we do it? How do we actually... You are the director of an institute. You've been told by your administrators this is a priority to deliver obesity or diabetes prevention. How do you do it? What is it that you need to do? So I want to tell you what I think the research has shown and what I believe is effective lifestyle intervention with behavior modification at its center. I believe that a good dose of a lifestyle intervention tends to have a fixed delivery sequence. And in the first half of programs, and these programs can be 10 sessions, 12 sessions, 16, 20, I'm not going to quibble about that because there are many, many good programs out there. But in the first half, what's important is the basic building blocks where you're really actually teaching the client or the participant the essential skills to change a behavior, any behavior, okay? The ones we, of course, focus on the most are those that have to do with eating and activity, and that involves self-monitoring diet. Dr. Jalalian mentioned, there are apps, you do it on paper, people write it in their notebooks, their planners. The important thing is to build self-awareness. Self-monitoring is important. And then they just learn whatever the nutrition guidelines are. The main point is to offer some guidance about diet and dietary quality, how to build an activity program, but most importantly, how what you are doing in your day-to-day life is reflected when you step on the scale. So the importance of having a calorie goal, the importance of self-monitoring, and the importance of weighing yourself is the feedback loop that the individual creates. So they begin to develop this sense of, wow, when I go away for the weekend and I don't self-monitor at all, I gain 5 pounds. 2 kilograms, that's the reason why we do those things, not because in and of themselves they're potent. And then understanding environmental cues, and I'm going to talk about that in a minute. And then it's not until the second half that we deal with psychology, and I get a lot of questions about this. I get a lot of questions from people saying, my clientele is stressed, they're depressed, they're anxious, I really need to deal with their psychological issues. And my argument is build mastery first. That is what the behavioral approach suggests. Let an individual go out and try to change a behavior. Sometimes they have success, it's a trial and error process, and they begin to develop that sense of mastery. If you start talking about the problems right away or the barriers right away, you will not engage them as quickly. So I say go for the self-control behaviors first, and then you have many, many weeks to be talking about barriers, strategies, problem solving, day-to-day stresses and lapses. So the DPP goals were pretty simple. I think in part that's what perhaps made it effective across so many different types of centers, is all participants were encouraged to work towards the same goal, their personal 7% weight loss goal from baseline, and they were asked to slowly build programmed and spontaneous activity of their own choosing, mostly walking, to 150 minutes a week. There were fat and calorie goals, which was to achieve and maintain the 7% loss of body weight by reducing fat intake to 25%. This is not a fat phobic or extremely low fat diet. It's what we call a prudent fat diet. And then otherwise, we gave them guidance on the nutrition guidelines. At the time that the DPP started, it was the pyramid. Now it's my plate. But the point is, it was a personal experiment. What do I need to do to meet those goals? And the calorie ranges were from 1,200 to 2,000 calories a day. So let me pause a minute, and this slide is worth about 4 slides, actually. But I just want to kind of give you a little bit of a narrative of what it is I would do if I brought you into a training program to teach you to deliver a behavior intervention over 12 weeks or 16 weeks or 6 months or a year. What is it that you as interventionist would be needing to do with your groups or with your individuals? I'm just going to walk you around the wheel. We're moving clockwise. So if you start at the top, one of the most important things in a behavioral program is for people to get engaged and come back. I often tell students, your goal in session 1 is for people to come back at session 2. That's your most primary goal. And the way we do that is we ask people to commit to the program as if it were a class. People get the idea of a class and a syllabus. And we spend a lot of time in the beginning of the program asking them to give very, very personal reasons for why they are there and are participating. So, and we want it to be personal at the level of, some people will say, well, I want to lose weight, duh. I want to prevent diabetes, but we want people to say, you know, I have 3 children, I want to be a good role model for them. You know, I'm a grandmother and I have to watch my grandchild and I want to be able to chase after him. I've seen diabetes in my family. You spend a good bit of time eliciting from your group what it is that's making this participation meaningful. And then you set the goals. Like I said, the 7% goal, you go about starting to instruct the group on how to do it. Ultimately, one has to tip energy balance. You know, I agree that some calories are better calories than other calories, but really the bottom line, what I have observed over many years, is that most of us simply have to eat less of them. And the question is, how will we eat less of them? And by offering people goals and letting the individual assess where they are now and where they need to go, a lot of learning takes place. So we build those healthy eating patterns. We teach individuals how to increase programmed and lifestyle activity. And they start to get a sense of what happens when they eat particular foods and particular amounts of food. Then this is the beginning of the behavioral, psychological, I believe, learning. Stimulus control and managing environmental cues. We ask people to envision what is a day in your life like? What are the cues that you're facing every day? Do you walk into a lunchroom full of pastries? When you come home, what are the foods that are on your table? We just get people to try to see what the environment is offering up to them. Because most of us go through the day not necessarily thinking about those things, and we help people begin to develop a sense of agency. And then, of course, inevitably, there are barriers. The individual says, I want to eat smaller portions or less of this kind of food, and then the family is unhappy because the cooking is different. And so then what we do is we teach skills for negotiating and communicating as a family, as a social group. And then somewhere along the way, we've got to deal with the thoughts, because one of the things that happens frequently in a weight loss, weight management, or even a weight prevention program is that individuals have moments where they feel it's just too hard and they want to quit. And so we have a lot of there's a lot of training that can go into helping people reframe a thought. The desire to, as I said, learned avoidance is normal. And so we need to work with our clients so that they do not feel judged. And they understand that wanting to not deal with something that's causing ambivalence is uncomfortable. We help them work with that and cope with that. And then the whole issue of building the culture of change. Well, if no one in my family wants to exercise and none of my friends want to be active, and we spend a lot of time eating on the weekends, where can I go to get more of something different? We talk about that. How can you make this happen in your life? And part of that is enhancing motivation and managing stress. So that's just literally, I usually spend 2 days training on those, but I wanted to give you a feeling for what's involved. Okay, so what is the evidence? This is all well and good, but does it help anybody? Does it change cardiometabolic parameters? This is what everybody wants to know. Well, here, and Elisa can concur with this, this is sort of behavior therapy history in one slide. We know that clinically meaningful weight loss of 5 to 10% is feasible and achievable for most adults in about a 6-month period. At best, with the most motivated, best attending participant, whom most of us don't see on a regular basis, you can hit that 10% at 6 months. It's just the laws of energy balance. The longer you meet with the participant, the longer the duration of your program, the greater weight loss you will see. Regain is physiologically and behaviorally normal, but not all individuals return to baseline. So for example, in the DPP and many, many other studies, roughly 25 to 30% of people will maintain weight losses, 5%, 7% weight losses. So if you think about that at the population level, and you get a lot of people doing this program, you will have a lot of maintainers. Of course, we need to work with those who are not maintaining as well. And the one thing we know about maintenance is the more contacts you have, the more accountability you provide for somebody to check in at a doctor's office, at a clinic, even a weigh-in. That's the Weight Watchers model, by the way. It will suppress the rate of weight regain. So 10% is feasible and achievable in the most motivated. In the large clinical trials, where we by definition are now going from ends of 100 to ends of 1,000 or 2,000 or 3,000, with more ethnic, regional, and racial variability, it's not uncommon to get 7 to 8% weight losses initially, and then 4 to 5% sustained for several years. In community translation, which is where all of you are probably looking for the most part, although you may be somewhere in between, it's closer to about a 5% weight loss that can be expected initially. And we don't have enough long-term studies of these translational interventions to really give you a reliable sense of how far out those weight losses go. So typical results of standard behavior therapy, this is based on work of Michael Perry, who kind of wrote the book on maintenance, is you see this peak of weight change and then the regain. And what we're all trying to do in weight programs is simply just suppress this as much as possible. And here's the rationale. The longer a person can have a reduced BMI, even if there's some cycling, but the longer period of time they're not exposed to the high BMI and the associated cardiometabolic risks, the further you're pushing the window of onset of chronic disease out. So even though some regain is inevitable, you want to try to suppress that to push symptomatology out as far as possible. And I think there was a lot of discussion about that yesterday, which was that, we're not reaching in Mexico City, reaching people early enough, and then even those who we are reaching aren't being treated adequately enough. And part of the whole point of treatment is to push untoward effects out further and further. And the other part of this slide is simply to point out that if you offer continued contacts, you will suppress the rate of regain, whereas if you just stop cold at 6 months, you can see a much quicker regain. I found this study, so I wanted to share it with you, was at the Biomedical Research Unit at the Mexican Social Security Institute in Durango. Somebody did a small study with a female sample, mean age 45, their baseline BMI was 36, and I thought this was really interesting. What they did was they first randomized them to a behavior change arm where they were taught these cognitive behavioral skills or they weren't. And then the group was further randomized within a skills to low fat or low carb or a no skills into low fat and low carb. And what you can see is just doing the diet, you got a little bump in weight loss, but if you added the behavioral skills, you got a substantial decrease in weight, close to the 10% that you see in a lot of academic studies. So I think this is a very small sample, but I wanted to share that with you because it's right here. Okay, so the reason I'm actually here talking to you is probably because of this slide that you see right here, which is that in the DPP, and I know many of you have seen this and read this study, that the cumulative incidence of diabetes was reduced by 58% in the lifestyle group over 2.8 years of follow-up. That was significantly more than metformin, and significantly more than the placebo. And I should point out that the metformin, which gives a nice little weight loss bump as well, was also significantly different than placebo and reduced risk by 31%. A very similar pattern was shown for the metabolic syndrome, with lifestyle reducing cumulative incidence of metabolic syndrome in those who did not have it at baseline by 41%, and the metformin group reducing it by 17%. And this is what the weight looked like. So basically it was about a 6.2 kilogram or 15-pound weight loss, and then the slow regain that you see, but not back to baseline. And this is shown in a different way, relating change in weight from baseline in kilograms. Here's minus 15 kilograms, and here's weight gain. And then on the y-axis, we have the incidence rate per 100 person years. And what you can see is that if you lost 15 kilograms in the DPP over a period of about 3 years, you were essentially, your chance of diabetes was essentially 0, and of course, increasing. And this was the lifestyle effect right here. And when we did hazard ratios, what it showed was that for every kilogram of weight loss, there was a 16% reduction in diabetes risk. So even minimal weight loss, kilogram for kilogram, is meaningful in an obese individual who has impaired glucose tolerance. Weight loss really is critical and drives the initial reduction in risk. I don't have the slides here, but there was also, for individuals in the first year of treatment who did not meet the 7% weight loss goal but met their activity goal, there was a 44% reduction in diabetes risk. So even activity in the first year reduced risk, but weight loss was the driver. And I think what we all know, anyone who's done anything in weight control knows that that initially the diet is what drives the weight loss, but in order to maintain any kind of weight loss, you really need a lot of physical activity, a lot of movement. Okay, how am I doing on time? Because I don't have a clock here. How many more? Okay, so I wanted to just also point out, this is the work of Delia West. This was published in Obesity in 2008, to say that although Hispanic individuals are at increased risk genetically, as is Pacific Islanders, Native Americans, and African Americans, that the weight loss for the Hispanic individuals in the DPP was on par with the mean weight losses for the groups as a whole. So at 1 year, Hispanic women lost 5.8 kilograms in the DPP, and Hispanic men 7.5 kilograms, which parallels the whole group, men losing more than women. And you can see those weight reductions there. Basically, the bottom line is, how did the weight loss happen? Individuals figured out a way to shave about 450 calories out of their diet per day. That really, at the end of the day, was one of the key ingredients, and they did that mostly by reducing dietary fat. The lifestyle group did change their mean leisure physical activity, and all of these things had beneficial effects on glucose, HbA1c. And one thing I like to point out, one of the benefits of a lifestyle intervention, one of the reasons why I believe it's good medicine, is it's a big bang for your buck. So I can give you a glucose-lowering drug. It can act very nicely, and it can be very beneficial. But here, the triangle represents the lifestyle. What we showed was that in the DPP, body size and shape change is what was in part responsible for decreasing diabetes risk. So it wasn't just BMI, it was reductions in central adiposity, and these were measured by CT scan. So you can see here, where am I pointing this thing? Right here is the lifestyle, and up here is the metformin and placebo, that in both men and women, things like visceral fat, subcutaneous fat also changed with the lifestyle intervention. So, and I'm not even talking here about things like energy and sleep and quality of life and well-being. So I think lifestyle interventions are actually even sometimes being used alongside depression treatments because they improve quality of well-being. And this is perhaps the most important DPP feature and finding, and I'll stop there. I have more slides to go, but I think I'll stop there so we can have questions. One of the things that makes me happiest about this trial, because I've been involved in a lot of weight studies showing even better results than we found in the DPP, was we were mandated to get 50% from non-white, non-Caucasian, and we nearly achieved that. And so there were 508 Hispanic Americans, so 16% of the DPP group was represented by Hispanic Americans. And what you see here is essentially in every group you looked at, even though the weight losses were different, the weight losses were not as good in African American women, although they were better than had been seen in many prior studies. But in every single case, the lifestyle incidence rates were better than the metformin and the placebo. So should I stop here? I have a few more slides, but I can stop. Stop. Okay, good.